Well, hello everybody, and I would like to welcome you all in this second series of the heart failure program directed by Professor Ahmed Shawqi and the IAVA board. I hope you enjoyed the first one, and this is the second, and still we have a third part in the coming weeks. In these occasions, I would like to welcome my dear colleagues and friends, Nabil Farag, Said Farag, Mohammed Salim, Bendari. And I don't know why Ahmed Shawqi, maybe something prevent him from joining us, but he is the director of this program. And I will leave the stage to Professor Nabil to introduce the first presentations. Professor Nabil.
Thank you, Dr. Ashraf, for these regular meetings. Actually, it's regular educational and teaching meetings. Very important to have such meetings in our daily activities. It's my pleasure to be with you and with our friends, Dr. Said Farag, Dr. Mohammed Salim, and I have the pleasure to introduce Dr. Ahmed Al-Bendari. Dr. Ahmed is an excellent speaker. Usually I enjoy your presentations, Ahmed, very, very much.
Thank you, sir.
You are very active, actually, sharing in a lot of activities in Egypt and in Europe, and I admire things you are doing.
Thank you, sir.
Ahmed is going to present a very important topic, which is the management of heart failure in patients with chronic kidney disease and hyperkalemia. Well, it's a very hot topic, and want to hear from you.
Thank you, Professor Nabil, for this kind introduction. And I'm also thankful for the board of IAVA for inviting me. It's always a great pleasure to be with you all. First, I'd like to announce any time my voice or my streaming is lost, please inform me directly. Don't hesitate to unmute yourself and tell me. Today, we are going to discuss actually a complex case which is really met in everyday clinical practice to us as cardiologists, which is management of heart failure in the context of chronic kidney disease and hyperkalemia. And this will be our agenda today. We will start by giving the personal history and then going to the examination findings. Then we will discuss different treatment options in a very interactive manner through multiple choice questions, which are left for the audience. Each question is left for 10 seconds as a voting system for the audience. And finally, we will leave by taking some take-home concepts or take-home messages. Our case is a female, Mrs. MP, which is 72 years old. She doesn't work. She is a pensioner. She is non-diabetic and non-hypertensive with no significant past medical history, and she presents with progressive shortness of breath of 4 days duration. Her blood pressure was 120/70 millimeter mercury. His heart rate was 76 beats per minute and regular and felt well peripherally, but she had bilateral pitting lower limb edema up to knees. Her lung auscultation revealed bilateral basal rails or crackles. She was with elevated jugular venous pressure, and importantly, her apex was in the 7th intercostal space at the anterior axillary line. And this is our first question. What do you think the differential diagnosis, the most important and the most probable differential diagnosis in this case? Is it heart failure, pulmonary embolism, COPD, or others? We will leave the question for 10 seconds and then we will illustrate the answers. Okay, ICOM, can we have the answers, please?
Is it easy for the attendee to use this voting system?
So most of our audience went to heart failure as being the correct answer, and actually this is the correct answer. Let's move to the next question. What would your investigations include? Will you include just ECG, or just echo and chest X-ray, or just blood chemistry, or we will include all of the above mentioned investigations? The question also will be left for about 10 seconds for our dear viewers to answer. Can I present the answers to us? And we will go to the explanation for the answers in the upcoming 2 slides. Actually, as I can see, most of the audience again made it correctly. They went to all of the above as being the investigation that should be included in such a case. If we went to the guidelines and see what are the symptoms and signs of heart failure, we will find that we have what we call typical symptoms and more specific signs, in addition to what's called less typical symptoms and less specific signs. Our patient is having one typical symptom, which is breathlessness, and the 2 important more specific signs, which are elevated jugular venous pressure, in addition to a laterally displaced apical impulse. And also she is having one less specific sign, but an important one, which is peripheral edema. All these makes heart failure the first differential diagnostic consideration in such patients. And if you go to the 2021 classification of heart failure in the most recent guidelines, you will see that whatever the ejection fraction category, whether less than 40%, the reduced ejection fraction, from 41 to 49, the mid-range or mildly reduced, or more than or equal to 50%, you will see that the number 1 and the most important criterion is the presence of symptoms and signs. Please remember, friends, that this is an integral part in heart failure. Heart failure will always remain a clinical diagnosis. It's a condition that could be diagnosed based just on signs and symptoms on the bedside. Remember again, heart failure is a clinical syndrome. Heart failure is heart failure is heart failure. And when coming to the laboratory results of our patient, we will see that all laboratory results were normal except for an elevated serum creatinine of 2.4. And this was the ECG of the patient. As you can see, she is in sinus rhythm. The complex is a little bit wide, and mostly she is having an incomplete left bundle branch block. But if you could see here, we have a more than 1 millimeter negative deflection for the B wave in V1, which is denoting left atrial abnormality. This was the chest X-ray of the patient. As you can see, an obvious cardiomegaly. The cardiothoracic ratio is high. In addition to the Mostic sign, which is denoting pulmonary congestion, as you can see, the pulmonary vasculature is more evident in the upper 1/3 of the lung and is exceedingly going the lateral 2/3 of the lung fields. What I'd like to say is that chest X-ray is usually ordered in patients with suspected heart failure in order to exclude other pulmonary etiologies that could contribute to the differential diagnosis list. And as you can see here, the chest X-ray denotes an evident pulmonary congestion in addition to an evident cardiomegaly. And now let's look to the echocardiography of the patient. As you can see, the left ventricular internal dimensions are quite high. The end systolic is 5.1 and the end diastolic is 6.5, in addition to an almost global hypokinesia with an estimated ejection fraction of 25%. So to conclude, our patient is having a clear heart failure with reduced ejection fraction, in addition to chronic kidney disease and her potassium, as you can see in these laboratory results, is 5.2. So she is on the hyperkalemic side. Let's ask this important question. Do you think that creatinine level is more than enough to assess the renal function of our patient? Who would go for yes and who would go for no? We have 10 seconds to answer. ICOM, can we have the results, please? As we can see, most of our dear viewers went to the answer of being no. But a considerable category, about a quarter of our viewers, said yes. They could be satisfied with creatinine level, just the creatinine level, to accurately assess the kidney function. But the correct answer is no. The creatinine level per se is not more than enough to assess the kidney function. You should always depend on the glomerular filtration rate. This is very important. You should always, again, depend on glomerular filtration rate. But why? This is because all classifications of chronic kidney disease into stage 1, 2, 3, and the advanced stages are dependent on GFR, because GFR takes into account the patient's age, the patient's gender, the serum creatinine itself, in addition to the lean body weight. And there are many equations to calculate the GFR. The most important one of them is the Krotkoff-Gault equation. But fortunately, we now have many applications and user-friendly applications on the mobile phones that could calculate the GFR in a fraction of 10 or just 15 seconds. And this is very important. We calculated the GFR in our patient, and it was found to be 34 milliliter per minute, which means that our patient is having grade 3 or stage 3 chronic kidney disease. Keep this in mind throughout the presentation. Let's have and ask another question. After you initiate medications for heart failure in this patient, which will include, of course, a RAS inhibitor such as ACE inhibitor, or even some RAS inhibitor drugs, when should you reassess the kidney function and the potassium level? Would you reassess the kidney function after 1 week, 2 weeks, 3 weeks, or you can wait safely up to 4 weeks to assess the kidney function? We have 10 seconds to take the viewers' opinions. ICOM, can we have the answers, please? We have here a divide, but again, most of our viewers made it correctly. The correct answer is A. You should assess the kidney function and electrolytes just after 1 week from initiating heart failure medications in our patient. And this has been stated clearly in the guidelines. If you can read, a follow-up serum creatinine and potassium should be made after 1 week from initiation. And if you found an increase in creatinine level to more than 30% of the baseline value, or in the presence of uncontrollable hyperkalemia, the dose of ACE or ARB should be discontinued altogether, or at least should be titrated to a lower dose. And in the context of these kidney functions, please look with me to this question and try to answer. Would you prefer to initiate an MRA or mineral corticoid receptor antagonist to the patient or an SGLT2 inhibitors, or you would not to prefer either of them? The question is left for about 10 seconds for our dear viewers to answer. ICOM, can we have the answers, please? Wow. Again, a divide, but the vast majority went to the answer number B. They would prefer to initiate an SGLT2 inhibitor for this patient, and this is correct, and this is great. But why not to initiate an MRA for this patient? If you look to the guidelines, focused exclusively, as I can point here by my laser pointer, to the contraindications against initiation of an MRA in patients with heart failure, you will find that the eGFR should not be less than 30, but the GFR of our patient is 34. At the same time, the serum potassium should not be more than 5. And remember, our patient's serum potassium is 5.2. So it's not very preferable to start an MRA for this patient. On the other hand, I'd like to draw your attention to a very important trial, that's DAPA-CKD, which is a trial that tested the benefit of dapagliflozin as being one of SGLT2 inhibitors in patients with chronic kidney disease with and without diabetes mellitus. In short, this trial entered patients with chronic kidney disease whose GFR was ranging from 25 to 75. All patients were with albumin creatinine ratio of more than 200 to less than 5,000, and stable maximal doses of RAS inhibitors within the previous 4 weeks, again with or without diabetes. Those patients were randomized between receiving dapagliflozin 10 milligrams or placebo on top of the standard of care, and they were followed up for an important primary renal outcome and other important secondary outcomes that included important cardiovascular endpoints, namely cardiovascular death and hospitalization due to heart failure. And sit down for this. In this trial, we had a significant 39% relative risk reduction in favor of dapagliflozin in this important primary renal outcome, which was composed of sustained more than 50% reduction in GFR, the development of end-stage renal disease, or renal replacement therapy. And when looking specifically to the important cardiovascular endpoints, which are hospitalization due to heart failure or cardiovascular death, again, we had a significant 29% significant relative risk reduction in favor of dapagliflozin. And the most interesting point is that this was consistent with other trials of dapagliflozin in heart failure, such as DAPA heart failure trial, which proved the benefit of dapagliflozin in heart failure with reduced ejection fraction. And this trial will be discussed elsewhere in this course. But the point that I'd like to draw your attention to is that if you looked closely to the inclusion and exclusion criteria of DAPA heart failure trial, you will find that investigators excluded those patients whose GFR was less than 30. But remember, our patient's GFR is more than 30, it's 34. So from a renal standpoint and also from a cardiological standpoint as well, SGLT2 inhibitors in general, and specifically, I could say dapagliflozin could be given to this patient. Now, let's move to a practical and a little tricky question. Which of the following medications can be used in HFrEF or heart failure with reduced ejection fraction, regardless to the GFR? In other words, whatever the GFR, you can use it. Is it RAS inhibitor or MRAs or sacubitril valsartan that's marketed under the name Entresto, or beta blockers? I leave this question for 10 seconds for our dear audience to answer. Can we have the answers, please, icon? Wow, the audience are always making it correctly. Most of our audience, again, went to the correct answer, which is beta blockers. And this is a very important piece of information. Friends, please remember that beta blockers, according to the most recent guidelines, is one among the 4 important pillars, which are all given class 1 recommendations to be given in patients with heart failure and reduced ejection fraction. But the point I'd like to make or to draw your attention to is that 3 out of these 4 pillars have RAS inhibitor properties, namely ACE inhibitors have RAS inhibitor properties, MRA have also RAS inhibitor properties, and even sacubitril valsartan have RAS inhibitor properties and therefore can escalate or cause some sort of deterioration in GFR after their use. And also SGLT2 inhibitors, despite their improvement in the GFR decline rate over the long term, they cannot be used down to GFR 30 in case of dapagliflozin or 20 in case of empagliflozin. We have cutoff value. But beta blockers can be used whatever the GFR, down even to GFR 15 or 10. Please keep this in mind. Don't deprive your patients as long as the beta blockers are not contraindicated from the great benefits of beta blockers. Think with me with this question. How to manage the potential hyperkalemia in this patient after we initiate heart failure medications? Should we just check for concomitant medications? Should we only avoid high dietary potassium? Should we just suffice with potassium chelating agents, and we have many of them on board as we will discuss now? Or should we can use all these strategies combined? I leave this question again for 10 seconds to have the voting system to work. Can we have the answers, please, icon? Wow. Nearly almost all of our audience went to the correct answer, which is all of the above. Actually, you can use all these strategies in every single patient. And within the upcoming few minutes, I'll discuss these strategies separately. First, the point that I'd like to draw your attention to is that the incidence of hyperkalemia in patients with heart failure vary widely. And despite the fact that major trials of RAS inhibitors in heart failure, including ACE inhibitors, MRAs, have only showed just a mild or modest increase in the incidence of severe or life-threatening hyperkalemia, this incidence appears to underestimate the real incidence in real life. And this is simply because the patient in RCTs are like this one. He or she are very controlled, in complete contrast to our patients in real life, which sometimes do not usually attend their appointments and also do not usually follow up their laboratory results. So, the incidence of hyperkalemia in real practice appears to be much more higher than we think. The second point I'd like to make, if you looked into these 8 major risk factors for the development of hyperkalemia in the general population, you will find that our patient is having 6 out of these 8 factors: heart failure, our patient is, of course, having HFrEF, the older age. Our patient is having an old age, more than 72. Baseline hyperkalemia, the baseline potassium level in our patient is 5.2, and this is important. And finally, renal failure combined with heart failure. Our patient is having a heart failure in the context of chronic kidney disease. So our patient is having a majority of risk factors to develop hyperkalemia, especially that you will initiate hyperkalemic agent in this patient. Please keep this in mind. Also, please remember to look to the dietary potassium containing ones. Importantly, dietary potassium could be an important contributor to the development of hyperkalemia, especially in the combination between CKD and heart failure. So, our patients are always advised to have low potassium diet containing less than 2 to 3 grams of potassium per day. And in contrast to the general belief among the public, many fruits and vegetables contain an unacceptable amounts of potassium. Also, energy drinks, some meats, some nuts, and cereals should be looked at. Also, we should look to the herbal remedies. And in Egypt, we have a lot of patients taking herbal medications. Please give the patient 1 or 2 minutes to explain to him or her the hazards of having much potassium-containing diets in their medications. Also, some medications can have a detrimental effect on the potassium level. One of the most important and frequently prescribed medications in Egypt are non-steroidal anti-inflammatory drugs. They are sometimes prescribed to those females who are older in age and having problems with their joints. They can lead and reduce renal function, they can reduce renal blood flow, and they can augment the propensity to develop hyperkalemia. Some antibiotics, such as trimethoprim, can inhibit the aldosterone-sensitive sodium channels and lead to increased incidence of hyperkalemia. Also, some immunosuppressive agents, such as cyclosporin, anticrolimus, and finally, some azole antifungals, such as ketoconazole, can also interfere with the biosynthesis of aldosterone and reduce aldosterone levels and increase the propensity towards hyperkalemia. Please give also an additional few minutes to revise the over-the-counter medications that our patients are taking. And if you would like to have an overview of the most important rising measures that could be used in patients with emergency or life-threatening hyperkalemia, we can have calcium that could be given intravenously acutely to protect the heart, but unfortunately, it's only effective for just 30 minutes. We can also do alkalinization of the urine, but it will likely work if underlying acidosis is present. Otherwise, it will not work. We can also have glucose insulin infusion, but please keep eye on the glucose level because of the incidence of hypoglycemia with using this regimen. And finally, you can have loop diuretics, but unfortunately, loop diuretics acts slowly after 30 to 60 seconds. And of course, they will not act altogether in patients with advanced renal impairment. And I'd like to draw your attention to the novel mineralocorticoid receptor antagonist, namely finerenone, which is a novel selective non-steroidal mineralocorticoid receptor antagonist, which has been recently studied in the important randomized Figaro DKD and Fidelio DKD trial, with encouraging significant improvement in important cardiovascular endpoints and a great propensity towards a lesser incidence of hyperkalemia. And this is important. And on board, we have now the potassium chelating agents or potassium binders, which I think that could be a magical solution for hyperkalemia in patients with heart failure, especially that they are given hyperkalemic agents or potassium retaining agents, such as RAS inhibitors and MRAs. And we have 2 on board. The first one of them is Teromer, which is marketed under the name Viltassa. It's a potassium binder that's available in a powder source. It can be given in 8.4 gram once daily to be increased by 8.4 gram increments per week to a maximum dose of 25 gram based on the potassium level. It has been studied in the important randomized OPAL-HK trial in patients with chronic kidney disease receiving RAS inhibitors, and as you can see on your right hand, it resulted in a significant reduction in the time to first potassium level more than 5.5 and significant reduction in the time for potassium level more than 5.1, and this feels good. The second potassium binder available is the zirconium cyclosilicate, which is marketed under the name Lokelma. And it's a potassium binder that preferentially exchanges potassium for hydrogen and sodium throughout the GI tract. It can be given in a dose of 10 gram 3 times daily for up to the first 48 hours. And then we adjusted the dose by 5 gram daily on 1 week interval based on the potassium level until a maintenance dose hovering around 10 gram once daily. Zirconium cyclosilicate has been evaluated in this important phase 3 randomized double-blind placebo-controlled trial in patients with heart failure. This was an exclusive heart failure trial that was published in the European Journal of Heart Failure. And as you can see on your right hand, each dose of zirconium cyclosilicate, whether 5, 10, or 15, resulted in a significant reduction in potassium level and maintenance of normokalemia. And if you would like to put all the FDA-approved potassium binders for the long-term management of hyperkalemia in context, look with me to this table which compares kayexalate to patiromer to sodium zirconium cyclosilicate. I will leave this table for all audience who would like to refer to it and the presentation after I finish. Finally, we come to a tricky and really practical question. What should we do really if the patient develops hyperkalemia while on RAS inhibitors? Should we stop RAS inhibitors altogether? Or we should just down titrate the RAS inhibitors and use other strategies just discussed, such as avoiding high dietary potassium and potassium retaining drugs, in addition to the potential use of potassium binders. What do you think, my dear viewers? 10 seconds are left for the answers. Can we have the answers, please, Icom? Oh, I feel now very comfortable. The vast majority of our audience went to the practical question answer as following. They will down titrate the RAS inhibitors and use other strategies to mitigate the risk of hyperkalemia. And I agree. Please look with me to the Emphasis heart failure trial, which one of the landmark trials in the field of HFrEF. This trial studied eplerenone as being an MRA in patients with heart failure and reduced ejection fraction. And despite the fact that the occurrence of worsening renal function and the hyperkalemia was more frequent in patients after the initiation of eplerenone, the occurrence of these adverse renal outcomes did not eliminate the survival benefit of eplerenone. In other words, the survival benefit of eplerenone remained even after the occurrence of some worsening in renal function and some elevation in potassium level. Another prospective propensity matched study in patients with heart failure, which was published recently in the European Heart Journal, showed that all-cause mortality was higher among patients who did not use RAS inhibitors compared to those patients who used RAS inhibitors. And some may come here and say Bindari, and this is understandable for the general population. And I agree. The most interesting and the twisting point is that this relation was consistent and more robust even among those patients with severe renal insufficiency. What I'd like to say is that please, friends, try to keep your patients even on a very mild dose of RAS inhibitors as long as their kidney functions and their potassiums are tolerating. This will ensure that our patients are gaining the mortality benefit they deserve from heart failure medications. My final take-home messages for the sake of time could be as follows. Please, remember that ACE inhibitors, ARBs, and MRAs decrease mortality and morbidity in heart failure. But when used in combination, they could heighten the risk of serious hyperkalemia. The next point is that patients must be selected carefully when these medications are initiated, considering their medical comorbidities such as chronic kidney disease. The third point I'd like to leave before I finish is that we should give attention to over-the-counter medications such as non-steroidals, to some supplements and herbal medications which could enhance the risk of hyperkalemia unnecessarily. Please keep eye on your patient and monitor the potassium level and kidney function on weekly basis after initiation and then regularly with each clinical follow-up. Finally, we have on board now the novel MRAs such as the selective non-steroidal finerenone, in addition to some potassium chelating agents such as patiromer and zirconium cyclosilicate, which could help to further mitigate the risk of hyperkalemia. I'm grateful that you listened. Thank you. This was me, Ahmed Bindari, signing off, and goodbye.
Thank you very much, Dr. Ahmed, for this excellent presentation. I would like to start just small discussion. I'll start by myself with a small question about the hyperkalemia you mentioned. If the patient is already on ACE, ARBs, or sacubitril valsartan, at which level of potassium would you reduce the dose, and at which level of potassium you have to stop these drugs?
Thank you, Professor Nabil, for this very important and practical question. When we go to the guidelines and see at which level of potassium should we look again to the dose of RAS inhibitor medications, you will see that the guidelines divided the hyperkalemia level into two major categories. One of them is the serious potassium, about 6, at which you could give a patient a chance to reduce or to stop altogether the RAS inhibitor medications, but we should always give attention to the over-the-counter medications, some high dietary potassium containing drugs, fruits, vegetables, and so on, but of 6. This is a serious hyperkalemia according to the most recent European guidelines for managing heart failure.
We have a question from the audience about the use of beta blocker in the presence of edema. Is there any precautions or any steps?
A very important note is that in the just finished presentation, when we spoke about beta blockers, we are speaking about a general concept for the general patients of heart failure and reduced ejection fraction. But when it comes specifically to the patient discussed, she was actually having a peripheral lower limb edema and pulmonary crackles. And one of the most important caveats and the prerequisites that should we give attention to is that the patient should be in a stable condition and nearly euvolemic before initiating beta blockers to them. But we just wanted to draw the attention of our dear viewers that beta blockers should always be entertained during discussion about the 4 pillars to be given for HFrEF patients.
Okay, Salim.
Thank you, Ahmed, for your excellent presentation. Our patient GFR is 34. And so in such patients, I think starting of SGLT2 inhibitors early can give some renoprotective effect in a way that I can initiate later on after 10 weeks or 2 weeks or something. I know that the cutoff value of initiating MRA is 30, but 34 for a practical purpose is near 30. And so I recommend for myself to start SGLT2 inhibitors. And after 10 days or 2 weeks, this will give some renal protection to start the MRA more safely. This is my comment. My question to you, you know that in heart failure patients, the kidney and heart is in accordance to each other. The cardiorenal axis is very important. And it is important to identify where the condition started. Is it in the heart and then to the kidney, or in the kidney and then leads to the heart? You know very well what's called cardiorenal and renal cardiac syndromes. Is there any practical or clinical predictors that can identify which organ starting the problem? I know this is a difficult question a little bit. Sometimes we don't know, but I think there are some clues to concentrate our efforts to correct the derangement of the primary organ responsible for the metabolic problem.
Thank you, Professor Salim, for this challenging question. I will go directly to the answer of your question, and then I will comment on your comment regarding the GFR and the SGLT2 inhibitors. It's very difficult, quite difficult in real practice to differentiate where the condition starts. But you can depend on two important items. The first one of them is the history. For example, if the patient is giving a long-standing history of hypertension and then you found that he or she is in CKD stage 3, mostly the hypertension is the cause, not the kidney. If this patient is giving a long-standing history of heart failure, which is not the case in our patient, and then you find the creatinine to be elevated and the patient to be in a certain stage of CKD, mostly this is denoting to the fact that the heart may be the initiating organ for the cardiorenal syndrome. On the other hand, if both conditions present concomitantly, especially if the type of the patient is denoting that the condition might be starting in the kidney, such as those folks we see who are middle in age or young age, developing acute presentations of dyspnea or oliguria and so on. This might point to the fact that the kidney might be the originating organ. And in this case, to cut the story short, the final answer could be put by renal biopsy. And this is a common practice for our dear nephrologist colleagues. This is the answer from my point of view. But before I leave the mic to you to comment on my answer, I'd like to draw the attention of our viewers to a very important practical point. When you initiate SGLT2 inhibitors in patients with CKD, please expect a reduction in the GFR in the initial few weeks. And this is a completely normal physiological action of SGLT2 inhibitors, because what we see in real practice is that many colleagues are stopping SGLT2 inhibitors when they see an elevation in creatinine or reduction in GFR in the first 2 or 3 weeks after initiation. We tell them that this is physiologic. The importance or the merit of SGLT2 inhibitors is in the reduction in the long-term rate of decline in GFR. So please keep your patient on SGLT2 inhibitors because they will definitely on the long-term benefit.
Thank you, Bendari. Actually, we have questions from the floor about in this situation, can we start the minimal dose of RAS inhibition to achieve mortality benefit? And I think this is very important questions because we have to try our best to give the patients the main pillars in the treatment of heart failure, which is RAS inhibition is one of them, or Entresto, or in addition to SGLT2 inhibitor, beta blocker, and MRA. So I think we have to do our best, treating the heart failure, correcting the hyperkalemia a little bit, to because if we don't give these patients the cardioprotective drugs, the mortality reducing agents, I think we can do a better job if we can use smaller doses. And so what's your opinion about that?
I totally agree with you, Professor Reda, for this concept. I will wear the clothes of a colleague nephrologist when answering this question. He or she will say, definitely we should give. But please remember that every patient profile matters. In this patient scenario, starting RAS inhibitors without concomitant SGLT2 inhibitors, I think will do more harm than good. So, okay, for starting a small dose of RAS inhibitors, but you should give an SGLT2 inhibitor from day 0, and you should instruct the patient firmly about the great importance of following her potassium and creatinine after 1 or 2 weeks. As long as the creatinine is hovering in the range of 20 to 30% increase, I can continue the dose of RAS inhibitor. But if the creatinine elevates more than 30%, I will have the dose of RAS inhibitors or stop altogether. But a chance of RAS inhibitor should be entertained in every patient with heart failure and chronic kidney disease, taking the precautions I just mentioned.
Okay, if there is no other questions, I think we can take a 5-second break to prepare for the second presentation. Dr. Salim.
Welcome back again. This is the second part of our webinar today in the management course of HFrEF, and it will be presented by Professor Syed Farag, Professor of Cardiology, Zaazee University. Really, it's a very important and practical topic, and sometimes it's a very difficult and complex clinical scenario we are facing in our daily practice about the management of heart failure in low blood pressure. Professor Syed.
Good evening, everybody. Thank you, Professor Salim, for this kind introduction. I'd like to welcome you all, Mr. Chairman, and this fantastic EVA night of continuous medical education. I'd like to thank Professor Shawi for this wonderful up-to-date program. And also I'd like to thank Dr. Bendari for the fantastic presentation. Actually, as Professor Salim said, this is the one of the clinical challenging scenarios that I think most of us face in our daily practice, which is the management of heart failure in a low blood pressure. Unfortunately, we have a lot of evidences, and I have a lot of updated data came to the stage, which is supporting our management with evidence base. Actually, we will dive through the personal history, the examination, and the treatment options, and finally the take-home messages. Let's have a look to our patient, which he is a Mr. FA is a 49 years old male. He is a manual worker, which means he is under physical stress, a smoker, which is actually is one of the cardiovascular risks, non-hypertensive, non-diabetic, with a presentation of shortness of breath of 4 days duration, a recent onset of shortness of breath. The condition started 3 months is actually when the patient complained of fever. And of course, nowadays in this era, we have to think for anybody who is complaining of fever for the, of course, of COVID infection. He was diagnosed actually as COVID-19 with bilateral pulmonary infiltrates and received antiviral steroids and anticoagulation on an outpatient basis. However, now he is presenting because of progressive dyspnea, orthopnea, and lower limb edema, and I'd like from the audience to concentrate on those clinical data. Again, the examination here, the most challenging point here, which is actually the title of our presentation, is the presentation with hypotension the blood pressure is 95/65, with the heart rate is 102 beat per minute, regular and felt peripherally, bilateral pitting ankle edema, which is again one of the typical signs and specific signs for heart failure, lung auscultations, bilateral basal rales, and elevated jugular venous pressure, which is again pathognomonic here in such a situation for the heart failure. The apex in the fixed intercostal space at the anterior axillary line, again one of the signs which also give us a clue for the diagnosis of heart failure, and apical S3 gallop. Now we have the first question in our stream of this CME activity. What do the symptoms and signs suggest? It is the symptoms and signs are typical for heart failure. Signs are typical and symptoms are not suggestive of heart failure. Symptoms are typical and signs are not suggestive of heart failure. Or finally, both signs and symptoms are not suggestive of heart failure. Please vote. Icon will show us the results of the voting. Okay, we're back again after this question, and now I will jump to some of the evidences from the guidelines to tell us if those symptoms are typical or specific signs for the heart failure or not. If we have a look here for the typical symptoms and specific signs, we can find that the breathless, orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, fatigue, tiredness, and increased time to recover after exercise, and ankle swelling. Those are the typical symptoms, and I think the patient have a lot of those typical symptoms. And for the signs, I think the elevated GVB and also the presence of laterally displaced apical impulse and third heart sounds make those signs specific for heart failure. So I think that the answer, as I will show you now after this slide, should be that the symptoms and signs are typical for the heart failure. This is a very important slide which has a minor change from the previous guidelines that about the definition of heart failure with reduced ejection fraction, and those with mildly reduced ejection fraction before was nominated as heart failure with mid-range ejection fraction, and I think this one is new. And finally, the preserved ejection fraction. It's worthy here to mention that the first criteria which should be present on all heart failure phenotypes is that the symptoms and signs should be there. It's the second criteria, which is the systolic function, the ejection fraction, for those with reduced ejection fraction less than 40, for those with mildly reduced from 41 to 49%, and finally those with preserved ejection fraction, those with ejection fraction more than 50%. Actually, for those with heart failure with preserved ejection fraction, it's worthy here to mention that objective evidence of cardiac structural function abnormalities consistent with presence of LV diastolic dysfunction and raised LV filling pressure, including raised natriuretic peptide, should be there for those patients with heart failure and preserved ejection fraction. The second question here is about the investigation. What would your investigation should include? ECG, echocardiogram, blood chemistry, chest X-ray, or all of the above. It's very important to know your strategy in ordering the investigation as to put the strategy of your management. So I will leave you now for 10 seconds to plot the right answer. So let's have also the evidence about the investigations we should order. Here is the evidence from the guidelines from the European Society of Cardiology Guidelines 2021 about the class of recommendation, the class and level of recommendation for the investigation we should order. And you can find here that the BMB, NT-proBNP is a class 1 level of evidence. B, the 12-lead ECG is also a must with class 1 evidence. That's the transthoracic echo is a class 1, the chest X-ray is a class 1, and also the routine blood test for comorbidities, including the CBC, electrolytes and urea, thyroid function, fasting glucose, hemoglobin A1C, lipid, and iron status. All those are class 1 level of C recommendation for the heart failure. So we have to know by evidence that all those investigation should be done when you are suspecting clinically the patient with heart failure. Here is another important algorithm for the patients with heart failure, and this is also came from the guidelines, that the suspected heart failure patients are those patients with risk factors, symptoms and or signs, and abnormal ECG. And then we have to think about the NT-proBNP if it is more than 125 picogram per milliliter, or BNP, which is more than 35 picogram per milliliter. If yes, we have to jump to echocardiography, or if we have heart failure which is strongly suspected, or if the NT-proBNP or PNP are unavailable, which is actually the clinical situation we are facing in every day, that the unavailability of the BNP or NT-proBNP, but actually we will have some criteria from the symptoms and signs and ECG and risk factor which is supporting heart failure. We have to jump to echocardiography, which is feasible and available everywhere, to find abnormal findings. If yes, heart failure confirmed. So we have now to define the phenotype of the heart failure according to the ejection fraction as mentioned before. If all the above mentioned is not present, so heart failure there is unlikely, and we have to consider another or other diagnosis. So here again, the right answer is the symptoms and signs are typical of heart failure. This is the answer of the first question. And here are the laboratory results of these patients: serum creatinine 1.2, serum potassium 4.1, serum sodium 142, hemoglobin is 13.5, TLC is 6,000, platelet 170,000, ALT and AST are normal, but we can find here that the CRP is elevated of 230, which is coping with the suspected or confirmed actually infection and inflammation. Here is the ECG for the patients, and it showed us actually here the left bundle branch block, and the X-ray, which is also showed us here the increase in cardiothoracic ratio with cardiomegaly, and also the increase in bronchovascular marking and pulmonary congestion, which is also give us an add-on point for confirming the diagnosis of heart failure. And the gold standard here is the echocardiography, which showed us the ejection fraction of 35 with global hypokinesia, mild mitral regurgitation, left atrium 45, which is actually increased, moderate tricuspid regurgitation with pulmonary hypertension, atypical echocardiographic data, which is going on with myocardial dysfunction, systolic myocardial dysfunction, and which is correlated with the clinical heart failure. Now, if we know that it is clinically confirmed by evidence that this was a heart failure, what is the cause behind the heart failure? Because, of course, as you all know, if we know the cause, if we know the pathology behind the heart failure, it may help us in putting the strategy for the treatment of this patient and also the prognosis of this patient. Does it myocarditis, myocardial infarction, pulmonary embolism, or just a coincidental attack of heart failure? Please give your answer. Again, let's dive to some of the evidences which will support the pathogenesis behind this heart failure attack. First, I'd like to give you an information, of course, which is a confirmation that the patient caught a COVID infection, that the PCR for COVID-19 was positive. Here is a very important graph, which is published in the European Society of Cardiology, actually after some time from the pandemic of the COVID-19 and its affections in the pulmon, on the lungs and on the heart. Here, the SARS-CoV-2 with the viral invasion to the type 2 pneumocytes and to the pericytes and to the myocytes, which leads to inflammation and cascade of mediators and cytokine storm like interleukin 6, 7, and 22, and CXCL10, which leads to myocarditis and fulminant myocarditis because of immune activation, which leads to myocardial damage and elevation of troponin, CK, and myocardial dysfunction and damage, and of course, heart failure and arrhythmias. On another hand, they make some this cytokine storm and these inflammations and these viral invasions to the microvascular will lead to microvascular dysfunction and lead to plaque instability and plaque rupture and acute coronary syndrome. So we can see here how grave is the SARS-CoV-2 or the COVID-19 for affecting the pneumocytes and also the myocytes and leading to the grave complications of myocarditis and heart failure. So here the right answer, of course, will be myocarditis, because the patient is proved to have COVID-19 and with clinical, typical, and specific symptoms and signs for heart failure. So the cause was mainly the myocarditis, which is the cause for his heart failure. What does the mechanism behind the depressed LV systolic function for these patients? Of course, the myocardial damage caused by viral infection, as I mentioned in the previous graph, is very important part for the pathogenesis of this myocarditis. And also is an indirect way by respiratory failure and hypoxia. And also immune mechanisms is not far for the to be blamed for myocardial inflammation and the myocarditis. Does it be all of the above or not? I will leave you for the 10 seconds to answer this question. Okay, it is typically all of the above, and it is explained clearly in the previous graph that all the previously mentioned, from the direct viral infection and indirect respiratory failure, and also the immune mechanisms for the inflammations were blamed for the myocarditis of this patient. Of course, now we have a lot of tests for COVID-19, either to the nucleic acid amplification test by PCR or antibody-based immunoassay for IgM and IgG, or the antigen-based immunoassay for the spike protein, or even the clinical test by CT. I think now the level of expertise is there everywhere to confirm the diagnosis of COVID-19 and to confirm our diagnosis of myocarditis because of the COVID-19 infection. Now we come to the practical question. What should be the treatment strategy for such a patient with 95/65 heart rate, blood pressure, and heart rate of 100 O2 beat per minute? What would be the treatment strategy? The small dose of ACE inhibitor plus beta blocker, the SGL2 inhibitor and ivabradine, small dose beta blocker and ARNI, MRA plus beta blockers, or any other suggestion. This is the challenging step in the decision making for such a patient to select the treatment strategy, or at least the starting treatment strategy, because sometimes after the start and after improvement of the clinical condition of the patient, sometimes the strategy also should be changed. So we have to think here for the current status of the clinical criteria by what strategy we should start. I will leave you again for 10 seconds to think about this question. Of course, it is worth here to mention and to say that yes, we have an evidence for all the mentioned drugs, but actually in the patient of heart failure, because of a lot of clinical presentations we faced, you have to tailor your medications. You have not to stick to even with one of the evidence-based guideline mentioned medication, because sometimes the clinical scenario of the patient deprive him from one of the medications or two of the medications, or changing your mind about the start. So I think here I will go for some of the evidences which may give the clue for this question. Of course, it came up to the stage also a few weeks ago from the guidelines that the ACE inhibitor here is recommended, class 1 indication, beta blocker, of course, MRA, and what's new in these guidelines and what's come very strongly in these guidelines is the SGL2 inhibitor, dapagliflozin or empagliflozin, are recommended for patients with HFrEF to reduce the risk of heart failure, hospitalization, and death. And if we have a look here to the class of recommendation, it's class 1 level A recommendation, which means multiple randomized clinical trial. So I think it is a very strong evidence, and it is born strong, as you see here, with this level of evidence. And finally, of course, the sacubitril valsartan is recommended as a replacement of ACE inhibitor in patients with heart failure with reduced ejection fraction, again to reduce the heart failure, hospitalization, and death. And if we have a look and dive in the other recommendations for the guidelines, of course, the diuretics is class 1 for improve of the exercise capacity and elevation of the heart failure symptoms and reduction of the heart failure hospitalization. Here is a change from the previous guidelines that the ARB here will be a replacement for the ACE or ARNI if we have any contraindication for both of them, also with the class 1 recommendation. And one of the important molecules, of course, is the IF channel inhibitor, the ivabradine, and those patients who can not tolerate the beta blocker from the start because of reason or another, especially also the low blood pressure, and if they are on the maximal tolerated dose of beta blocker and is not still reaching the target heart rate, which is 70. I think also it's very worthy to mention this molecule here with this level of evidence, which is 2A. And I think also this evidence here will help us in the answering the previous question. Also, we have the Versiquit, which is the adenine cyclase stimulator, and those patients with class 2 or 4, NIHA class 2 or 4 with a level of evidence or class of recommendation 2B, level of evidence B, and hydrolazide isozopide dinitrate for those also should be considered in Black patients with reduced ejection fraction who are not yet compensated despite the treatment with an ACE inhibitor or a beta blocker MRA to reduce the risk of heart failure and hospitalization. And here is the class level of evidence B or class recommendation 2A. Digoxin, of course, as usual, it is in the last, the bottom of the list. The digoxin may be considered in patients with symptomatic HFrEF and sinus rhythm despite treatment with ACE, ARNI, beta blocker, MRA2, also to reduce the hospitalization. This is with B level of evidence. This is also one of the very important evidences which came up from the American College of Cardiology also this year before the European Society of Cardiology for those patients of HFrEF stage 3 treatment. As first step, ARNI ACE ARB was ARNI preferred, and the evidence-based beta blocker, this is the first step if the hemodynamic of the patients, and I'd like here to underline, if the clinical criteria of the patient, if the hemodynamics of the patient allow you to use those molecules, because as we all know, when the patient blood pressure, systolic blood pressure especially, is below 100, I think it is so difficult to initiate treatment with these vasodilator drugs or with beta blocker for the fear of hypotension in such heart failure patient, which I think will deteriorate his clinical condition. Then if the patients with EGFR more than 30, create more than 2.5 for males and less than 2 for females, with potassium less than 5 and NIHA class 2 to 4, we have to add the very important pillar, which is aldosterone antagonist. And for the patient meeting the EGFR criteria, we can also add the newcomer, the strong comer, which is the SGLT2 inhibitor for the patient with persistent volume overload, as we mentioned before, diuretics. And for resistant patient, we can also, especially the black one, we can also add hydralazine isozapide. And for those patients who are not achieving the target heart rate despite maximally tolerated beta blockers, or if the clinical situation cannot afford the beta blocker, we can, for those patients more than 70, we can add the ivabradine. So we have the evidence for all those molecules I mentioned in my question. So now it's clear to mention here that ACE and ARNI beta blocker, MRA, DABA and EMBA, loop diuretics are class 1 recommendation for patients. Yes, this is what the guideline mentioned, but we have to take in consideration the clinical criteria of the patient and hemodynamic criteria of the patient. Because in our patient, we have a blood pressure of 95 over 65. We look for the sinus rhythm and left ventricular ejection fraction less than 35, QRS more than 130. It is class 1 recommendation of the QRS complex more than 150 to add CRTD or B. And for those with QRS 130 to 150, it is class 2A recommendation to implant CRTD or B. For those patients with left ventricular ejection fraction less than 35, but the QRS is less than 130, where appropriate, the ICD here for ischemic is a class 1 recommendation, and for non-ischemic is a class 2A recommendation. So if we would like to have an answer for our question, the very challenging question, I think, after diving in the evidence from the European and from the American guidelines, we have the SGLT2 inhibitor as one of the pillar, and we have the ivabradine as one of the substitution for the beta blocker if the patient hemodynamics cannot allow the initiation of beta blocker. And I think, like our patient with his blood pressure 95 systolic, I think it would be too hard to initiate beta blocker. Maybe after the improvement of the beta blocker later on, we can add the beta blocker, because it's, of course, one of the first pillars in management of heart failure. And here we have an evidence for the SGLT2 inhibitor to add or to start or to initiate for those patients without affecting significantly the blood pressure for the patient. If we have some data and some evidence about this SGLT2 inhibitor, I can tell you here that, of course, for those patients with type 2 diabetes, there is a strong evidence for reduction of hemoglobin A1C. Of course, the body weight, sometimes this is for those for hypertension. There is an improvement for systolic blood pressure, and the systolic blood pressure also is there for those patients with type 2 diabetes when we use SGLT2 inhibitor. Of course, also in the cardiovascular outcome trials, you have a strong evidence about the benefits for patients with type 2 diabetes and high cardiovascular risk and established cardiovascular disease for hospitalization of heart failure. And here it is very important to mention that the hospitalization of heart failure is a very strong medical burden and also a very grave economic burden for healthcare authorities. So improving the hospitalization of heart failure is one of the main targets for managing or for strategic management for heart failure. Also, the cardiovascular death is marvelously improved with these SGLT2 inhibitors in different studies like IMPA-REG outcome, Canvas program, DECLARE TIMI, and also the VERTIS cardiovascular. And also improvement of this is there with those when using the SGLT2 inhibitor in such studies. Again, the reduction of cardiovascular hospitalization across the cardiovascular outcome trials with SGLT2 inhibitors. If we have a look here, we can appreciate that, of course, in all the studies mentioned, it is in favor with using the drug versus placebo. Also here, the SGLT2 inhibitor and those patients with multiple cardiovascular risk factors, also it is in favor again of SGLT2 inhibitor versus placebo for reduction of the cardiovascular hospitalization and cardiovascular mortality in those patients with multiple cardiovascular risk factors, which I think deserve to be mentioned here. What is important here is the SGLT2 for those patients with and without prior heart failure. Even for those patients with the first attack of heart failure, they still have a very strong evidence for benefit from the SGLT2 inhibitor, as we can appreciate here also from the different studies versus placebo. Again, in the IMPA-REG, DECLARE TIMI, Canvas program, and all those studies, there is a favor for SGLT2 inhibitor versus placebo. Sometimes all these studies, all these clinical studies, all this research sometimes need a real-world evidence, and here's a real-world evidence which gives more strength for this molecule, the SGLT2 inhibitors, over about maybe 500,000 population for a real-world setting. Again, if we have a lot here from different countries, from database from different countries and different continents, this is again a favor for the real-world setting for the beneficial effects of the SGLT2 inhibitor versus placebo in different countries and in the real-world setting. And the DABA heart failure, which I think turned the table upside down for those patients with heart failure with reduced ejection fraction, diabetic or non-diabetic patients. We can find here the trial, which I changed. It is the landmark trial, which changed the guideline, the reduction of about 26% relative risk reduction with number needed to treat equal to 21 for the dapagliflozin versus placebo for the primary composite endpoint, cardiovascular death, heart failure hospitalization, or an urgent heart failure visit. So we have a very strong evidence actually for this molecule with less adverse events and high safety margin as regard the volume depletion, renal adverse events. And I admire what Professor Bindari said about the reduction in EGFR or elevation of creatinine in the early period after treatment with these drugs, which we have not to taken in consideration. You have not to take in consideration, and I have to follow these patients because they might improve or they mostly improve the renal function of those patients with heart failure, fracture, amputation, major hypoglycemia, diabetic ketoacidosis. We can appreciate here that the p-value is almost non-significant for all these adverse events versus placebo. Another important point here about the change from baseline to 8 months as regard the metabolic parameters for the diabetic euglycemic or the glycemic status as measured by the glycated hemoglobin. We can find here between placebo and dapagliflozin a significant p-value, and also the creatinine reduction and the hematocrit and the NT-proBNP, the weight reduction, the systolic blood pressure improvement. All those are significantly improved with the use of the dapagliflozin versus placebo from baseline to 8 months follow-up. As a final question, do you think that SGLT2 inhibitor improve the LV remodeling? I think this is also an important question, because when we have a look to the in practice to the clinical response for those molecules, it is marvelous. But if we look also what is behind this clinical improvement, like the improvement in the LV remodeling, I think we will be more confident to use this molecule in these patients with heart failure. I will leave you for also 10 seconds again to answer it by yes or no. This is the evidence behind this question, the imperaturism age from 18 to 85, diagnosis of heart failure 2 to 3, left ventricular ejection fraction less than 50, stable symptoms and therapy for heart failure within the last 3 months, and randomization for those randomized for placebo and empagliflozin 42 patients. And if we have a look here to the results, we can find that the left ventricular end diastolic volume is significantly reduced from the baseline, and also the left ventricular end systolic volume also reduced. The percentage of reduction is significant from the baseline during all through the follow-up period, and also the left ventricular mass also significantly reduced, and the left ventricular ejection fraction is significantly increased with those patients who randomized for empagliflozin versus those patients with placebo. And also as regard the pulmonary function, the peak VO2, the QAS, the 6-minute walk test clinically, and also the clinical questionnaire, we can find here also the significant improvement for those patients under empagliflozin versus placebo. So now we can confirm that the SGLT2 not only improving the clinical situation, but also it is improving because of the improving of the LV remodeling, there is a marvelous improvement in the clinical situation and in the clinical status of those patients. So of course, yes, the SGLT2 improved the LV remodeling, and here it's also worthy to mention that even with the CMR, this is confirmed that the remodeling, LV remodeling, is improved with those patients. As a take-home message, of course, heart failure is a rising problem worldwide and accounts for greatest number of hospitalizations. And reduction of hospitalization and improvement of symptoms is an important cornerstone in the management, of course, of these patients. HFrEF can present, of course, because we are in the era of COVID-19, so the myocarditis is there and can be the cause of myocarditis and heart failure with reduced ejection fraction. And finally, which is very important, the management of HFrEF should be assessed according to the different parameters of patients. Including, of course, the blood pressure and heart rate, as in our patient. Yes, we have an evidence for a lot of molecules, but we have to tailor our management according to the blood pressure by using those drugs who are not affecting so much the blood pressure, and those drugs who are reducing the heart rate without affecting the blood pressure, as I mentioned, with ivabradine and with SGLT2 inhibitor. And finally, I'd like to thank you all and have a nice night again.
Thank you, Said. Actually, this is a difficult scenario when you face a patient with heart failure and hypotension. And I think one of the solutions you presented is to use ivabradine instead of beta blocker if patient cannot tolerate. However, what about device therapy? We know that device therapy is now one of the cornerstone of therapy of heart failure in certain situation. Could it be one of this situation, severe hypotension, because we will not be able to give the maximum dose of all the drug necessary to manage a patient with heart failure? If there is a role for device therapy?
Thank you, Professor HFrEF, for this very important question. My answer first is actually yes. From the guidelines, from the algorithm, the ECC elaborated in their latest guidelines that those patients whose ejection fraction less than 35, like our patient, and with QRS more than 150, also like our patient. And I think we are handicapped for using the maximum tolerated doses because of this clinical condition. I think the device therapy with CRTB or CRTD will be there for such a patient. But here it is worthy to mention something. And sometimes after initiating some of the treatment, like we mentioned, SGLT2 inhibitor and ivabradine, sometimes the hemodynamics of the patient improved and allow you to use some of the other drugs which you cannot initiate with, like the ACE or ARNI, beta blocker, MRA, and by using those drugs, the clinical condition will improve more. And if this occur, I think we can delay the device therapy if there is a clinical improvement of those drugs. But if not, it is worthy to use the device therapy.
Yeah, I would like to comment, Dr. Said. I think today we have a very, very important message that SGLT2 inhibitors are the safest drugs to be used in patients with heart failure with reduced ejection fraction. Based on the presentation by Dr. Bindari, a patient with chronic kidney disease and GFR more than 30 and hyperkalemia, in this patient we can't use ACE inhibitors, ARBs, and even sacubitril valsartan, but it's safe to use SGLT2 inhibitors. And in patients with low blood pressure, like the patient you presented very nicely, Dr. Said, and low blood pressure also, it's risky to start with beta blocker or with ACE ARBs or even sacubitril valsartan, and it's safe to use SGLT2 inhibitors. I think starting with this drug in such patients who are very critical and risky to start an important drugs like ACE ARBs, sacubitril valsartan, to start with SGLT2 inhibitors will improve the condition, will improve the clinical situation of the patient. The blood pressure will go up, and this will help to introduce other drugs we couldn't use in first presentation. And adding other drugs as answer for Dr. HFrEF, starting with SGLT2 inhibitors, then will help to improve the patient, and adding other drugs and the clinical situation of the patient definitely will improve with use of all of the pillars we can use. And the ejection fraction can go up because we have the evidence that even SGLT2 inhibitors like dapagliflozin improve cardiac remodeling and LV remodeling and improve the ejection fraction, reduce LV size and LV volumes, left atrial volumes. All of this can end up with improvement in all of this, and we can avoid the use of device therapy in such patients that the ejection fraction can go up more than 35, and the left ventricular size can be reduced. And by this, we can avoid the use of expensive device like CRTD.
Yes, I totally agree, Professor Nabil.
Thank you, Dr. Said, for excellent presentation. I will take the last statement from Professor Nabil Farag to start my question and comment. Your case is still in the subacute phase following the COVID, isn't it?
Yes.
Okay. And so you know that the
3 months after the attack.
But still COVID positive, PCR
yes.
positive. Okay.
Yes.
And you know that the device therapy regarding the ICD and CRT after acute coronary syndrome may not be indicated except after 40 days, I think.
Yes.
But here in this condition, the duration after the viral infections or when there is an inciting agent leading to myocarditis is a little bit subtle, and for how long we can wait, because there is some patients the ejection fraction will improve and then the cutoff of 35 will come to 40 and then the device therapy will not be indicated. So my question, for how long we have to wait for the resolution of the pathology and the final state of the LV remodeling, even before starting of other medications that will potentially will improve the ejection fraction?
It's a very nice question, Professor Slim, and it is worthy here to put it on the discussion table because, as we all know, that we are now in the, if we can mention, in acute era. We cannot have a strong evidence for anything about the what is the proper recovery period after the COVID, because as we all know, it is almost 18 months, and we cannot judge from it is individually variable from person to another. But I think it is worthy to mention here something that, as Professor Nabil said, we have to stepwise try our guideline evidence treatment and to look for the improvement in the ejection fraction after every step up with the one of the pillars we add on during the treatment strategy. If we have such a condition, we have such an improvement, of course we can omit the idea of the device therapy. But if we haven't, after the proper period, which is, I think, for every pillar, which is about 6 to 8 weeks, from 6 to 8 weeks, we have no improvement. I think we have, and we cannot step up for another pillar or another dose titration. I think we have to think about the device therapy, especially if there is no clinical improvement. But I think there is no, if anybody can correct me, there is no now evidence-based period for how much we have to wait for the recovery for the COVID-19 till we decide about the that the pathology is fade away or not.
Yes. I think another point, dear colleagues, that we should test for in patients with heart failure, because as you know, we want to help these patients by all the means, is to check serum ferritin, regardless of the hemoglobin level. Even if the hemoglobin is okay and the serum ferritin is low, these patients may benefit from replacement therapy in these situations. I think this is in the guidelines now.
Yes, it's true, Professor HFrEF, and that's why the ferritin and the transferritin saturation is now, and I think we are underutilizing those laboratory investigation because it is a class 1 indication to test in those patients with heart failure, actually.
Okay, if there is no other comment or questions, I think it was very educative and very difficult clinical scenario. We all want to know how to solve, and I think we get important informations about the different management strategies in such difficult cases. I would like to thank you, thank the audience, thank AstraZeneca and ICOM, and thank you, my dear colleagues, and see you in the next series. Thank you.
Thank you all.
Thank you. Bye-bye.
Bye-bye.